think we're going to go ahead and get started so we can try to stay on schedule. First of all, welcome everybody to Stanford on a Saturday. It's not bad weather for the fall. We have an excellent program today with a number of illustrious speakers here, so I hope you'll have a great time today. A couple of logistics in terms of the way that the day is organized. We're going to have a series of sessions that are grouped by 2 or 3 speakers in each session. We ask that you save any questions to the end of the session. So if there's 3 speakers, let all 3 speak, and then we'll have a open question. There are 2 microphones, 1 on each side here. So when we get to the question and answer session, we ask so that everybody can hear your question that you use one of the microphones. If anybody's looking for the restrooms during the day, you have to actually go out that door and then walk along. And there's another door outside there with 2 orange cones. That's where you go restroom. Out that door, you're going to be trapped, and you're going to be trapped between 2 doors that only open with a special card key that probably most of you don't have. So we'll periodically check in that area for any hostages. So we're very excited to have the VHL Alliance here with us today. I think we've been working with the VHL Alliance for about 12 years here at Stanford. It's however long V has been working here. She coordinated the whole thing. They have an excellent support system, as many of you probably know, a lot of resources, and we're just totally happy to be able to participate with them in person. I think this is the first time we've done a symposium here at Stanford. So I'm going to let Chandra make a couple of comments.
Good morning, everyone. Thank you, Dr. Chang, again for hosting us. So I just want to again welcome everyone to our family meeting, our annual family meeting. It is such an honor to be able to meet patients and families and caregivers in person, because it's one thing to serve the VHL community virtually, but when you get to meet everyone in person, it reminds you that everything that you do is with purpose. And so at the core of what we do at VHL Alliance, it really is all about our community, our VHL community. So we want to thank you for coming out and spending your Saturday with us. I want to thank Dr. Chang, V, and the entire Stanford team for being gracious hosts. This has been a wonderful time of planning and getting to know one another. And Dr. Chang, the work that you do day in and day out is so meaningful and purposeful, and we thank you. And V, we thank you for going above and beyond for us every day. I also want to thank the VHLA staff and board of directors for diligently serving to advance the mission and vision of our organization. And I thank you to our patients, caregivers, and families. And we are partnering with you on this mission as we are diligently and forcefully working to find a cure for cancer through VHL research. So thank you.
Great. So let's start with our first speaker. Our first speaker is Nicki Chun. Nicki is with the Stanford Cancer Genetics and Genomics program, and I was just talking to her a few minutes ago. She was the very first person in that program, in the cancer program when it was founded. And genetics is such a big part of VHL, and they've really rapidly expanded their program. They're hiring ninth and 10th geneticists. So that's just amazing, phenomenal growth in that program. And certainly we welcome all your partnership with us. So Nicki.
Okay. Hi, welcome to California. It happens the way it is. There we go. Ready? Yeah. Okay. Don't let that dissuade you. There's beautiful things to see. If you just want to take a walk around campus, there's all kinds of nooks and art installations and meditation places. It's take advantage of that while you're here. So, okay. So I'm going to use the arrows, I think. Stanford Cancer and Genetics was established I always mark it by my youngest son, who is 22, because I got hired when I was on maternity leave with him. So a long time ago, and at the time, let me go to my first slide. At the time, BRCA1 and 2 had been identified. They came into genetic testing just before 2000, and I got hired in 2000 because all of a sudden we were starting to realize the benefits of the Human Genome Project in cancer. So you guys were not far behind here. So the reason I'm just going to catch people up, because I assume some people are newer to the association and some people aren't. So von Hippel was a doctor who first described this inherited type of retinal hemangiomas, and then Dr. Lindau described the hemangioblastomas that can happen in the central nervous system. So they put that together, and it used to be the convention when a new genetic syndrome was identified, they honored the people who first described it. We don't do that so much anymore. It's such a collaborative effort that's sort of antiquated. But von Hippel-Lindau, the gene was discovered in 1993, and you ask, why did it take 50 years or so to find the gene? It's because we didn't have the tools. We could identify families by characteristics, but we didn't have the tools to find out what inherited factors there were until late in the 20th century. So the gene was discovered, testing then became available. You'll notice it's almost exactly the same as BRCA1 and 2 timing wise, and we've been testing for it ever since. What happens when the VHL gene is not functioning? It's part of an important oxygen sensing pathway, meaning it detects when the cell is not getting enough oxygen, and it starts activating some compensation for that. So we think that's why the tumors in VHL have lots of blood vessels, is because one of the ways you get more oxygen, right, is supplying more blood. And as Dr. Chang noted, there's a lot of research going on to try and make life better and improve these symptoms. So this is dominantly inherited. Take you back to high school biology for 10 seconds, meaning you inherit 2 copies of every gene, including VHL, one from mom, one from dad. Dominant means if one of them is not working, this causes the condition. Even though this one is working, this is strong enough to cause the condition. About 1 in 35,000 people has VHL. That may sound extremely rare. In the world of genetics, it's not terribly rare, actually. So we do see, a reasonable number of people. If you work in tumor genetics or cancer genetics, you will see VHL every so often. 80% inherited, meaning that a parent passed on that VHL mutation and it's running in the family. 20% de novo, meaning there is no family history. It didn't exist before in the family, but this person has a brand new change in the VHL gene. So they're the first one. Once it's there and can be passed on, right? But every mutation in the human population started with someone. You already know there's very vascular tumors that develop, and most of them are benign, but rarely there is increased risk for malignancy, especially in the kidney tumors. Almost complete penetrance. Penetrance, we mean that if you have the risk because of a gene problem, how often do you develop a symptom or symptoms of it? So we used to say virtually 100%. And I think it's pretty close to that, to have at least something that tells us that gene problem is there. Average age of diagnosis is 26, and a fair proportion happen in childhood, usually the retinal angiomas or a pheo. And so when it's running in families, we tell them we have to test children, usually early in life, because we need to monitor them, because there are substantial risks. And monitoring means earlier identification, means better, more effective treatment, right? Okay, so this is just my graphic for dominant inheritance. I already showed you. So if one person has a VHL mutation, half the time that gets passed on in their egg or sperm cells, half the time it doesn't. That's why there's a 50-50 risk with each child. Only if you inherit it can you pass it on. So the children that don't inherit it don't have the risk and don't have the possibility of passing it on. And Dr. Chen's going to go over this more, but the areas of the body that are susceptible to VHL mutations involve, of course, the retina, the central nervous system, brain and spinal cord, the kidneys because of the pheochromocytomas that sit on top of the kidney. It's in the adrenal gland. Cysts in the pancreas and in the kidney, sometimes in the liver, and sometimes tumors that can grow in the pancreas. We call them PNETs for pancreatic neuroendocrine tumor. Okay, it's kind of a cute name. All right, and then less commonly, I would say you can get overgrowth tumors, but not cancer in these broad ligaments, females and males. So I ran across this. I thought it was kind of clever with, it's not a perfect mnemonic, but to remember, how do you spell Hippo? Because I always think, is it E or L or LE? But hemangioblastoma, increased kidney cysts and cancer risk. Okay, well, it was forced fit. But pheochromocytomas, pancreatic cysts or tumors, eye, retinal hemangioblastomas, and liver cysts. Okay. So what do you look for as far as symptoms? The most common early presentation is having some retinal involvement. So you may start to see some disturbance in vision, headaches because hemangioblastomas, vertigo, those endolymphatic tumors in the ear can cause symptoms. And blood pressure spikes up and down because of the pheochromocytomas pumping out hormones and making, it's the fight or flight hormones, right? And then hearing loss or tinnitus because of the endolymphatic sac tumors. Tumor suppressor. So most of the genes that we see in cancer are tumor suppressors. It means that if you visualize a car with two sets of brakes, we're born with these tumor suppressor genes, are two sets of brakes that when the cell is growing and dividing, it says when to slow down and when to stop. So you keep the cell at a normal, turnover rate, growing and dividing properly. If you have two working copies when you're born and you acquire a mutation in one, because we do have random mutations that happen in our cells all the time, you still have a backup. And it's only when that second copy also gets knocked out that you can get sporadic tumors. If it happens in the VHL gene, you'll get tumors like you see in VHL, but these are not inherited because you weren't born with a mutation. If you have inherited VHL, it's because you were born with one mutation in one of the copies. You still have a second one, but these cells are much more susceptible to a random mutation triggering tumor growth. Does that make sense? Okay, lifetime risk. This is a big, long laundry list. You probably know it. But one of the biggest risks is for the retinal growths, cerebellar hemangiomas. You'll notice that there's big borders on these estimated risks. Part of that is due to different studies with different groups of people coming up with slightly different numbers. Part of it has to do with what we'll talk about later, that different mutations in the gene can probably tweak these different risks. So for some mutations, the risk is lower, some mutations, the risk is higher. I'm not sure I need to go over all of these. I'm glad to pass them on to anyone that wants a copy of it. Okay. All right, so here's what I was asked to talk about is these VHL subtypes. So there was a broad split when we first started classifying, people with VHL have how much risk for how many symptoms. So the big split was between families where there seemed to be higher risk for pheochromocytomas versus higher risk for hemangioblastomas. So number one was the angioblastomas, retinal and CNS, and some of the other risks, the kidney cancer and the cysts and the PNETs, right? Most of those mutations are missense or truncating. So what that means is a missense is flipping one letter in the whole length of the gene, but probably at an important spot where it impairs the function. And truncating means you create a stop sign somewhere in that gene, so it can't make the whole protein, so it clearly isn't going to work properly. Type 2 pheochromocytomas are the dominant feature, less so with the other kinds of tumors that are seen. And again, most due to missense mutations. They further have classified these into 3 different subtypes for type 2. One where you see pheochromocytomas and the retinal and CNS tumors with a low risk for kidney cancer. 2B, where you see pheochromocytomas and a high risk for kidney cancers. And type C, where it's mostly pheochromocytomas and rarely some of the other tumors, okay? It's important to remember that, you know, we're kind of early in trying to classify these. Everybody would like a roadmap of what to expect for the future and better numbers of, you know, where their bigger risks are, but we're not there yet. So we can sort of broadly create subtypes and say, you know, this is sort of our estimate of it, but it's not a complete roadmap yet. So there's no current change in the way that we screen and treat people depending on the subtypes. It's an academic endeavor at this time, and we'll talk a little bit about why that is. Okay, so many of you have talked to you doctors when you got diagnosed with this. How do you get a diagnosis of von Hippel-Lindau? Well, if you have a hemangioma, more than one hemangioma, brain, spinal cord, eye, or if you have one hemangioblastoma and one of the other VHL findings, or if you have a family history, you just need one finding popping up because you already have, you know, a genetic risk, right? And of course, because VHL genetic testing is highly predictive, if you have a mutation in that, even, you know, in the absence of anything, we're going to screen for VHL. So 95% that meet the clinical criteria have these findings, one of these 3 findings, will have a finding in the VHL gene, but not everybody does. And we still need to follow you as VHL if you meet the clinical criteria, okay? So 80% of people have a family history. It makes it easier to know what we're talking about. 20% do not. What are the other reasons why somebody might not have a mutation identified in the VHL gene? So mosaicism. Remember I said that everybody had, every mutation in the human population started with somebody, and that can happen in the egg or sperm cell for the first time, and that person has that VHL mutation in all their cells. But it can also happen after the egg and sperm fertilization, and there is a small cluster of cells, and one of those cells acquires a mutation, so its descendants carry it, but the other cells in that person's body do not. So we call that mosaicism, as if, you know, a picture is made up of different pieces, right? Mosaicism is really hard. There have now been a fair number of cases of people who clearly have VHL, don't have any mutation found when we take a blood sample or saliva sample, but it's in some of their cells, so it's affecting the organs that are susceptible. And it's really hard to know, how can we find that? We can try things like doing a skin biopsy, or trying some other, if you're having surgery, trying some other tissue to see if we can find the mutation, because we can't find it in the other normally accessible cells. But that's not foolproof. You know, we can't test every cell in the body. So if it's not in the tissue we happen to be able to examine, we may not be able to find it right now. It also could be that there are, and we say this for like all the genes, we know genes that increase risk for breast cancer if there's a mutation. It could be that there are control mechanisms for these genes. So other genes or factors in our DNA that tell the gene when to turn on and off. And if they're faulty, it could still affect the same gene, but the structure of the gene is intact. And so we're probably missing genetic causes that aren't in the pure structure of the gene, okay? The other thing that can happen is that not so much in VHL. We haven't discovered a second VHL gene, but it's not impossible that maybe somewhere in that pathway there's another gene that, when it's impaired, can be like a copy. We call it a phenocopy, like so the physical features are copied by that gene, but we haven't found one yet. Okay, so there are a few incidental things to know about VHL if you really want to go down a rabbit hole in genetics. One is that there is another completely separate gene that, depending on its structure, there's one variable point in the structure, can increase the risk for especially hemangioblastomas. So if it has one variant, which doesn't hurt that gene itself, it's just a variant in that gene, but it seems to interact with the VHL gene and increase the risk. The other possible variant in that gene doesn't increase the risk. So that's called a modifier gene. It's not a causative gene itself, but it can shift the risks a bit by some kind of interaction that we don't fully understand. There's another gene, HSPC, it should be 300, that is what we call downstream from the VHL gene. So sometimes mutations are deletions. A chunk of the gene has been clipped out and it's just gone. And that's why the VHL gene doesn't work. If it is a big deletion, it could include this other gene. And depending on whether the other gene is also deleted, you get some variability in what your VHL symptoms are. So it's another modifier. And normally, if you have a big deletion, kidney cancer risk is increased. But if you delete this adjacent gene, it seems to decrease the risk for kidney cancer. Interesting, huh? And you may have come across this, this diagnosis, familial erythrocytosis. So they have discovered there's one place, actually there's two places that I read about in the VHL gene toward the end, where if there's a mutation, you don't have VHL, you have familial erythrocytosis. And it's recessively inherited, not dominantly inherited. So it takes that mutation in both copies of the gene before a person has that condition. They do not have VHL at all, okay? But they do have a lot more red blood cells, and they do have some cardiovascular risk for hemorrhage and clots and things. So you can forget about that, but I just wanted you to hear about it in case you come across it and wonder if you have that. You don't, okay? All right, finally, I don't know how well this projects. So we talked about how different mutations shift the risk for different findings in VHL. So this is just kind of a map. This is the way genetics people look at genes. Is the left side is called the 3' and the right side is called the 5'. And so that's the beginning and that's the end. That's where you start making the first building blocks to build a protein, and you end here. So the little triangles, you can see that there is some difference depending on where the mutation is, right? So let's see, the hemangioblastoma symptoms are the red triangles. And you can see that you can have it anywhere along the gene, but it clusters a little bit more on the right-hand side. The pheochromocytomas cluster, I'm sorry, I think I have that backwards. The pheochromocytomas cluster a little bit more on the right hand, the 5' side, and hemangioblastomas, and especially kidney cancer, more toward the front or the 3' end. But they're not definitive. That's why we can't use what we've learned about these tendencies to really guide screening yet, because there's still risk for the other symptoms. They just may shift the number a bit, okay? So I think that's it. Dr. Chang kindly appreciated our growing Cancer and Genetics and Genomics Center, which started, so we started 22 years ago, and we had 2 people at the time. We're now adding more. We're in all areas of oncology. Genetics has become so complicated that genetic counselors can't do everything anymore, so we kind of specialize in oncology or neurology or cardiovascular or the traditional prenatal genetics and pediatric genetics. But this is our team, and we're glad to see all of my colleagues can see people to get tested for VHL. If they have a finding, they get referred into our special clinic with Dr. Justin Annis, and I work with him in that clinic. So we manage the people that have VHL and help use the genetic information to help family members too. So that's my role, is to do the testing if it hasn't been done, to explain the clinical implications, to explain what it means for family members and what's the logical way to use this information to help relatives, who has the highest risk, and who can we eliminate, depending on test results. Okay. All right. Thanks for your attention.
It's gonna go to.
Just keep going.
Yep. And then goes to electron. He's after you. Okay.
Leave it.
Yep. Yep. Okay. We'll do it. No, let's just do all three, and then we'll do questions. Okay, the next speaker is going to be Dr. Julie Chun. She's a assistant professor in endocrinology. The endocrinologists have their national annual meeting going on this weekend. So Dr. Chun wasn't able to be here in person, but she has her presentation on video for us. And so we're going to go ahead and play that.
My name is Julie Chun, and I'm one of the endocrinologists at Stanford. I wanted to thank the organizers for the opportunity to speak today, even though I couldn't be there in person. Today, I will be discussing von Hippel-Lindau and the endocrine system. During my talk today, I would like to define endocrinology and describe what a hormone is, review the pancreas and the adrenal gland, describe the endocrine manifestations in patients with VHL, including pancreatic neuroendocrine tumors and pheochromocytomas, and finally review how to treat patients with adrenal insufficiency. Endocrinology is the study of hormones and the glands that secrete hormones. Today, we will be primarily focused on the pancreas and the adrenal gland, but there are endocrine glands throughout our entire body, including our pituitary gland, which is underneath the brain, the thyroid, which is located in the neck, and the reproductive organs such as the ovaries and the testes. So that naturally brings us to the next point, which is, what are hormones? Hormones are chemical messengers that travel through the bloodstream to various organs throughout the body and can affect a number of important functions, including growth, metabolism, and reproduction. The pancreas is an important organ in the body that is between the stomach and the spine. It has two main components. The exocrine pancreas secretes pancreatic enzymes, which help our bodies to digest food. The endocrine pancreas makes hormones, which act as chemical messengers once they're released into the bloodstream. An endocrine manifestation in patients with VHL are pancreatic neuroendocrine tumors, or PNETs. These tumors occur in the hormone-producing cells of the pancreas. If the tumors make excessive amounts of hormone and do not listen to the other signals from the body, They are known as functional tumors. If the tumors do not make hormone, they are considered to be non-functional tumors. The hormones the tumors can make include insulin, glucagon, somatostatin, and VIP. Insulin, glucagon, and somatostatin regulate blood sugar. Therefore, when there are abnormal levels of these hormones, this leads to the dysregulation of blood sugar. Insulinomas are tumors that secrete too much insulin. This leads to low blood sugars. The symptoms can include rapid heart rate, sweating, feeling shaky, vision changes, or even feeling confused. These symptoms typically resolve fairly quickly with eating. Glucagon and somatostatin secreting tumors lead to high blood sugars. Tumors that make somatostatin or VIP are also associated with GI symptoms, specifically diarrhea. Pancreatic neuroendocrine tumors and cysts can occur in up to 35 to 70% of patients with VHL. These tumors are mostly benign or non-cancerous and non-functional in that they do not secrete hormones. Screening for these tumors typically starts at 15 years old with an imaging scan and MRI of the abdomen. It is recommended that the MRI be repeated every 2 years. Treatment is surgery, especially if the tumor is over 3 centimeters or seems to have a faster rate of growth. In addition, surgery is recommended for patients who have a certain genetic signature. After surgery, if a lot of the pancreas needs to be removed in order to remove the tumor, and there are not enough of the endocrine cells which make insulin, then patients can develop diabetes, which needs to be treated with insulin and should be under the care of an endocrinologist. Next, we'll be discussing the adrenal gland. The adrenal gland is a small triangular-shaped gland located on top of both kidneys. The adrenal glands produce hormones, which are chemicals that regulate things such as metabolism, blood pressure, response to stress, and other essential functions. The adrenal gland is also composed of 2 distinct parts. The outer part is called the cortex, and the inner part is called the medulla. Each part will release different hormones, which then go into the bloodstream and act on various body tissues. Here are a list of the hormones that are secreted. The top 3, aldosterone, cortisol, and androgens, are released by the cortex, which is the outer layer of the adrenal gland. Catecholamines are released by the medulla, which is the inner layer of the adrenal gland. Aldosterone is important for blood pressure as well as regulating water and salt balance. Cortisol is a key hormone for the regulation of blood pressure, blood sugar, weight, and metabolism. Androgens from the adrenal gland have weak effects compared to the male and female reproductive hormones. Catecholamines make adrenaline, which is important for the body's flight or fight response. Pheochromocytomas and paragangliomas are important endocrine manifestations of VHL disease. Again, these tumors produce the hormones that cause the fight or flight response. Pheochromocytomas are tumors that occur within the adrenal medulla. These types of tumors that occur outside of the adrenal gland are called paragangliomas. In VHL disease, pheochromocytomas are much more common than paragangliomas. These tumors in general are quite rare. In the general population, they occur at an incidence of 2 to 8 per million per year. About 10 to 20% of patients with VHL will have one of these tumors. The mean age at diagnosis is typically in the 20 to 30s. This is compared to sporadic cases in which the average age for diagnosis is in the mid-40s. This is possibly because the tumors may develop earlier or because there's a higher detection rate through increased screening and surveillance. The tumors can occur bilaterally, but they are usually in the adrenal glands, like we mentioned, and so they're called pheochromocytomas. And fortunately, these tumors have a very low risk of cancer and are mostly benign in up to 95% of cases. Based on the genetic mutation, patients can be categorized into different subtypes. Patients with type 1 are at very low risk for pheos, whereas patients with type 2 will typically have pheos or paras. Type 2 is then further subclassified into 2A, 2B, and 2C. For subtype 2A, these patients are at low risk for kidney cancer. For 2B, these patients are at high risk for kidney cancer. And subtype 2C is generally associated with pheo and paras only. So what is the screening recommendation? Screening for patients with VHL should begin at 2 years old with annual blood pressure monitoring. Screening for the chemical markers of these tumors starts at 5 years old with annual plasma or blood or 24-hour urine test for fractionated metanephrines. Screening for tumors by imaging starts at 15 years old with the MRI scan of the abdomen and is recommended every 2 years. MRI is typically preferred over CT scans in order to minimize radiation exposure to the body. The tumors make catecholamines, which is important for your body's fight or flight response. However, many patients are actually asymptomatic at the time of diagnosis due to the routine screening that occurs in this patient population. The symptoms that patients may report include headaches, sweating, palpitations, or high blood pressure. Less commonly, people can have fatigue, dizziness, facial flushing, or nausea. The treatment for these tumors is surgery. However, the preoperative preparation is extremely important in order to block the effects of high adrenaline. Anytime these tumors are manipulated or touched, it can lead to a huge surge of adrenaline, which can place a lot of stress on the body. And therefore, the preoperative preparation is important to avoid the fluctuations in hormone levels that can happen during surgery. About 7 to 14 days prior to surgery, patients are typically started in what we call alpha blockade. This can include medications that are called doxazocin, prazosin, terazosin, and these days less commonly phenoxybenzamine. 2 to 5 days prior to surgery, patients are then started on beta blockade. These medications include metoprolol or atenolol. A couple days after the preparation has been started, patients are typically encouraged to stay well hydrated as well as increase their salt intake. The surgery can be done laparoscopically, which is a minimally invasive technique in which small incisions and tools are used to access the adrenal gland. This approach is considered to be effective and safe, and is oftentimes preferred because there is faster recovery time, decreased pain, and shorter hospital stays. Adrenal cortical sparing surgeries can also be considered, especially for children and those who have bilateral disease. The goal with this cortical sparing surgery is really to leave behind some normal, healthy adrenal tissue to avoid the development of adrenal insufficiency. Adrenal insufficiency is when the body cannot make the adrenal hormones. With this approach, patients can preserve normal adrenal function in about 25 to 50% of cases. Adrenal insufficiency in patients with VHL occurs oftentimes after surgery if they have bilateral disease or if they need to have both adrenal glands removed. If someone only has one adrenal gland, the one adrenal gland is actually usually able to make enough hormone for the body. The three hormones in the cortex are aldosterone, cortisol, and androgens. Fortunately, the adrenal hormones can be replaced with pills. So aldosterone controls blood pressure as well as salt and water balance and regulation, and it can be treated with a pill called Florinef. Cortisol controls blood pressure, blood sugar, and metabolism, and can be treated with pills, either hydrocortisone, which is dosed twice a day, once in the morning, once in the afternoon, or prednisone, which is usually dosed once a day. Androgens are your weak male sex hormones and typically do not need replacement. Since 40% of patients with VHL have bilateral PHIOs, which will require surgery, many of them are at risk for developing adrenal insufficiency. Therefore, I think it's important to discuss some key points for those who have adrenal insufficiency. The first is use of a medical alert bracelet. Patients with adrenal insufficiency should have a medical alert bracelet that includes their diagnosis and medications. There are medical supply companies that sell them online, or many of my patients are just able to find it on Amazon or through a local personalization store. The second point to discuss is the sick day rules. So during illness, it is very important to increase the dose of steroids. This is to copy what the body would usually do during times of illness or stress. This should only be done for minor illness, such as a cold or a stomach flu. And I always tell patients that if the illness worsens, you should definitely contact your doctor for further guidance. The rule I typically use is a 3-by-3 rule. So I recommend that patients take 2 to 3 times their normal dose for 3 days. For example, if someone is taking hydrocortisone 10 milligrams in the morning and 5 milligrams in the afternoon at baseline, and then they get sick, they should increase the hydrocortisone to 30 milligrams in the morning and 15 milligrams in the afternoon for 3 days. And then on the 4th day, if they're feeling better, they can decrease the hydrocortisone back down to their baseline of 10 milligrams in the morning and 5 milligrams in the afternoon. And finally, it's important to think about what to do in case of emergencies. So during emergencies, it's important to have injectable steroid at home. There's a type of injectable steroid called Activial, which is easy to use and package. Injectable steroids should be used in case of an emergency situation. For example, if the patient's found to be unresponsive or there's severe blood loss. Finally, if the patient has nausea, vomiting, and is unable to take their hydrocortisone pills, then I typically recommend that they go to the emergency room in order to get the steroid by IV. So in summary, today we have reviewed the 2 common endocrine manifestations in patients who have VHL disease, which include pancreatic neuroendocrine tumors and pheochromocytomas. Screening for early diagnosis is very important, and we reviewed the screening guidelines for both pancreatic neuroendocrine tumors with screening MRIs, as well as for pheochromocytomas with blood pressure monitoring, checking the labs, and imaging. Surgery is the treatment for pheo, but preoperative preparation is key. And after bilateral adrenal surgery, patients can be at increased risk for adrenal insufficiency. So this concludes my talk. Thank you so much for taking the time to listen and for attending our conference today.
Great. Our next speaker, Dr. Electron Kibibu, is the chief of general surgery here at Stanford and has been so for the last 5 years. And prior to that, he spent a decade at the NIH, where he treated and managed hundreds of patients with VHL. He has a ton of experience. He's our go-to guy for abdominal VHL disease here at Stanford. Looking forward to his talk.
Thank you. It's a pleasure to be here. I'd like to also thank Stephen V. and Chandra for putting on the conference. As Stephen said, my voyage in taking care of patients with VHL started at the NCI when I went there, where it was an epidemic. And I have learned along with the patients on what's the best way to take care of them. And I'm going to share that with you. I think Dr. Chun did a great job of setting up the common manifestations. And then I'll share with you, I think, information that's important as a patient that you should know, and where I think the state of the science, or art, if you will, is presently. So I have no conflicts of interest, nothing to disclose. I'm going to cover 3 main areas: define and diagnose endocrine manifestations. I think there are specific or granular information that it's, I think, important for patients to know. And then important consideration for management of the pheochromocytoma, paraganglioma, and pancreatic lesions. And I think Nicki gave us a great overview of the genetics, but I think the genetic information ready for prime time, especially for peanuts and how we manage patients. And the new HIF2 alpha, I think, has been a game changer. I've seen a handful of patients where I was ready to operate on that had dramatic response. So I've certainly tailored my management of patients with pancreatic neuroendocrine tumor, and I'll share that with you. As you already heard, pheochromocytomas and pancreatic neuroendocrine tumors could occur anywhere from 18% to 9% of patients with VHL. Really depends whether it's a cross-sectional study versus a natural history study. And that was one of the great things when I was at NCI. A 10-year natural history study where you really could understand who's at risk and who's going to progress or develop these diseases. You already also heard nicely how we diagnose pheochromocytomas. And many patients might be symptomatic, but with VHL, where one family member is identified, it's really diagnosed on surveillance and screening. And again, as I shared with you, this rate could be anywhere from 18 to 30%. I think patients should not get imaging just for pheochromocytoma. If you're doing it to detect a renal lesion, that's important, but it's really a biochemical diagnosis. And I'll go into that in a little bit more detail, because what happens is you will see an adrenal nodule that might be 1 centimeter. But if the biochemical testing is negative, the patient does not necessarily need intervention in that clinical scenario. So what is the most sensitive biochemical testing is the plasma fractionated norepinephrine and medinephrine. In children, that's obviously difficult to do. You don't want to do blood draws in them, especially if they're as young as 5 years of age. And urinary study would be adequate. What are the imaging studies that we use? You see there, MRI is often used because the minimal amount of radiation exposure. I'll share with you some data that perhaps we could actually use dotatate screening at 2 years interval, and it's actually a lower radiation exposure for patients with VHL, but it's got a characteristic intensity that lights up on T2 weighted image. That's a coronal image of your body going from front to back, and you could see a left adrenal pheochromocytoma there. Similarly, CT scan is just as accurate and gives you anatomic information. Also, the likelihood of whether you might be able to do adrenal sparing, adrenalectomy, or cortical sparing, I should say. And I've had a handful of patients, 3 to be exact, that actually had, one had a carotid body tumor, one had a paraganglioma next to the duodenum, and then you see this patient with a large paraganglioma around the renal hilum. So paragangliomas, it's a potential risk, but are not very common. The other imaging that we use, both in patients with pheochromocytoma and neuroendocrine tumor of the pancreas, are nuclear medicine scans. You ask why? Well, do they have another primary tumor, a paraganglioma that would be, or if they have a pancreatic solid lesion on imaging and we're thinking it's a neuroendocrine tumor, the main reason to do any surgical intervention is the risk of malignancy. So you want to see if they've got metastatic disease. And there have been nice studies in the literature that compared head to head, both in patients with pheochromocytoma and paraganglioma, as well as neuroendocrine tumors of the pancreas. And I'll share with you some studies we did. This is a whole body image, FDG PET, that's available everywhere. This was used in many patients with cancer. Dotatate, which is taken up by the somatostatin receptor, F-DOPA, and F-dopamine. In head-to-head comparison, as you could see, you don't need to be a physician, that you could see more tumors on the FDG PET and the dotatate. So I usually get those imaging studies to determine whether there's other sites of tumor or metastatic disease present, which would dictate the need for surgical intervention. I think it's important for you all to know we've come a long way. It's almost been 100 years since the first adrenal operation that was done by Rue and the Mayo brothers in Rochester, Minnesota. Dr. Chun went over very nicely. It used to be the risk of complication and death was about 50% in the 1920s. Because of alpha blockade, intraoperative hemodynamic monitoring, and management, that mortality rate now is really less than 1% of patients would die from an adrenalectomy for a pheochromocytoma. And as Dr. Chun outlined, minimally invasive approach, laparoscopic, videoscopic, robotic, all result in a smaller incision, less pain, faster recovery time, shorter time in the hospital. And then now we have a wealth of data. And I'll share with you that if you have a pheochromocytoma, regardless of how big it is, because the risk of it being metastatic, unless somebody in your family had a malignant pheochromocytoma, that you should only get a cortical sparing adrenalectomy. And then some data specifically to VHL, the genetics genotype phenotype association, primarily in neuroendocrine tumors of the pancreas, and the refined imaging that we're able to manage patients much better and has resulted in excellent outcomes. So I didn't want to prepare a presentation focused towards other healthcare providers. I knew it's going to be patients here. And I thought, what are the relevant questions, or what are the questions I commonly get in clinic when I'm seeing a patient with pheochromocytoma that are initially being screened or in our surveillance program? Well, the guidelines suggest that we should do screening 1 to 2 years for pheochromocytoma in patients with germline mutations in the VHL gene. What I often get is, at what age should we screen? You saw perhaps very young age, and I'll share with you data that I think we should start screening. What are the intervals? Should we really be screening patients every 2 years? I'll share with you some data that we should be doing it every year. And what do you do when there's a lesion, but the biochemical testing is normal? Does that patient need an operation? And then do you remove the whole adrenal gland? This is a study that we did in 273 patients with VHL when I was at the NCI, specifically with these questions in mind, because there's really no relevant literature to guide us and guide the patients that we were seeing. As you could see, no surprise, about a third of the patients over the natural history study had developed a pheochromocytoma, and only 3 patients with paraganglioma. And no surprise, the median age was in their 30s. And what was really important is the earliest age of diagnosis of a pheochromocytoma was in a young boy that was 5.5 years of age. And when we looked at it, this accounted for 7% that were 10 years and younger. So it's important that you start screening it at age 5, and you could use urinary 24-hour collection for norepinephrine and medinephrine. And it's a significant number of patients. 7% of the cohort had developed a pheochromocytoma before age 10. How about those patients that have a lesion that's detected, and we repeat the biochemical testing? Perhaps we'll even wait until they're symptomatic and it's still negative. This is a nice study done by the group and recently published at NCI with Stanford and colleagues. And they followed patients that had negative biochemical testing, but a lesion that was up to 1.5 centimeters. The typical rule is, and what I share with most of my patients, is a pheochromocytoma usually needs to be about 2 centimeters before there's significant catecholamine secretion or adrenaline levels that are elevated. And they nicely show that they were able to follow these patients in just active surveillance with no hypertensive crisis or pheo crisis. And I think what the most important take home is this: some patients were followed for up to 10 years. So if the biochemical testing is negative and there's a small nodule, it is quite safe just to monitor the patient. How about the results of partial adrenalectomy? And who is eligible to have a partial adrenalectomy? In that same cohort, we looked at that in patients who had a partial adrenalectomy. Only 8 of those patients had a total of 9 recurrence. So 14% of those patients with a median follow-up time, that is median, half of the patients were followed for 10 years. So that's a very relatively low recurrence rate. And that happened anywhere from within a year to up to almost 40 years during follow-up. So partial adrenalectomy is safe and durable. And what's most important is none of those patients developed metastatic disease or malignant disease. In fact, out of all the patients I've taken care of with VHL-associated pheochromocytoma, there was only one patient who was the first family member that was diagnosed with an 8-centimeter left pheochromocytoma that ended up having malignant or metastatic disease. So partial adrenalectomy is very safe in this situation. And I think you heard from Dr. Chan in children with bilateral pheochromocytoma. I actually think we've got to treat every adrenal gland like it's the last one. because I think patients with VHL will have a lifetime of operation ahead of them. So if you have a pheochromocytoma just on one side, you should think about doing a partial adrenalectomy regardless if the opposite side adrenal gland is normal, because the risk of you developing pheochromocytoma in the future is not insignificant. This is a nice study specifically done, relatively small sample size, showing in pediatric patients with bilateral pheochromocytoma. There was only 8 patients, but the most important take home, unlike what Dr. Chun was saying, actually 80% of patients do not develop adrenal insufficiency after partial adrenalectomy, and the risk of recurrence very similar to what we found of 14%. Only 2 out of the 8 patients develop recurrent pheochromocytoma in the remnant gland that was not cancerous. And as you could see, the time to recurrence was quite long, 4 years in one patient, 6 years in the other patient. So my approach is, and I don't want to scare you with these videos, is really the optimal operative approach in patients with pheochromocytoma, regardless of how big the tumor is and the technical details of sacrificing the adrenal vein or the artery. I've been surprised that in most patients, if you leave an adequate remnant, that it would be functional, and it obviously would avoid the risk of adrenal insufficiency in the future, as well as the need for steroid replacement immediately. In some instances, again, the unusual setting where in the family there's a malignant or metastatic pheochromocytoma, a total adrenalectomy would be reasonable. And almost every patient should be offered a minimally invasive approach. This could be done through the back, it could be done through the side. There's really no reason to do an open operation with the longer recovery time associated with this. So for the pheochromocytoma, it's easiest to manage when it's a small tumor and it's detected early. That affords the possibility of doing the cortical sparing adrenalectomy. Make sure if you're seeing a surgeon that's going to do the operation that they do an ultrasound, because sometimes there's smaller lesions that could be just shelled out, and that you have a partial adrenalectomy. I'm going to switch gears then now and talk about pancreatic lesions associated with VHL. I'm not only going to talk about neuroendocrine tumors of the pancreas, because actually pancreatic cysts are much, much more common. 70% of patients with a germline VHL mutation will develop that. You see a CT scan. Many times these cysts are diffusely throughout the pancreas. And there are 2 risks associated with pancreatic cysts. These almost never require an operation, but if they grow to such a size, they could have a mass effect on the adjacent organ. The second thing, which I think not enough providers do, is screen patients for exocrine insufficiency. You heard from Dr. Chan. Our pancreas is responsible for secreting digestive enzymes. So many patients, when probing them and questioning them, do you have flatulence or diarrhea, specifically when you're eating fatty food? Many patients will confirm that fact. And it's no surprise, because as you could see on the CT scan, what happens is all of these multiple cysts replace the normal pancreas. So it's important to pay attention to that, because the remedy and treatment is quite simple. It's just taking pancreatic enzyme replacement to take care of those symptoms. The second diagnosis is serous cyst adenoma, and I'll go into that because sometimes these tumors could look like a pancreatic neuroendocrine tumor, but have no malignant potential or cancerous potential like pancreatic neuroendocrine tumors. So I told you about pancreatic cyst, and really rarely does it cause local obstruction. I've operated on only 2 patients as a result of that, in probably following over 800 patients in the last 15 years. I've been taking care of patients with VHL. Sometimes it could cause a mass effect, as I shared with you. The patient that had their biliary tract obstructed and required a stent, and we need to remove all of the pancreas. But that's a very, very, very rare manifestation. I would say probably 1 in 5 patients, they have exocrine function insufficiency and could benefit for pancreatic enzyme replacement. So next, I'm going to talk about the other lesions, the serous adenoma, right? I already told you this tumor has no cancerous potential, but sometimes when we look at the CT scan or the MRI, it could look like a pancreatic neuroendocrine tumor. And lessons learned, we did operations on these patients. I say the pathologist always has the final answer, and it comes back as, oh, it wasn't a pancreatic neuroendocrine tumor. And specifically, the ones associated with VHL are serous solid adenomas. And having done pancreatic operations in patients and getting this pathology back, we asked the question, how could we better determine this up front and not subject patients to an operation? I don't care what center you're at, pancreatic operations are associated with significant complications and approximately a 1% risk of dying from it. So it was really important to us to do the operation for the right disease. So as I shared with you, we've been using the FDG PET or the dotatate scan to determine whether the cancer is spread or not. And this is the data from the FDG PET scan, and it shows pancreatic neuroendocrine tumors compared to those solid microcystic cyst adenomas have a much lower uptake. So this is information that's important up front. If it has low uptake, even if it looks like a neuroendocrine tumor, that we follow those patients. I call it the great masquerader, if you will. So the clinical dilemma and questions we get from patients is, what's the risk of cancer? How do we better stratify it and determine whether you need a surgical intervention? If it's growing, it's the same question. But I think it's important for you, you heard from Dr. Chun, tumors that develop from the endocrine cells, we call them islet cells in the pancreas, can secrete all these hormones. And you don't need to worry about that because we screened all patients every year over 10 years. And the neuroendocrine tumors that form in the pancreas of patients with VHL are all non-functional. They don't secrete extra insulin, they don't secrete extra somatostatin, gastrin, or VIPoma. So they're all non-functional, so you don't need to worry about that. The main question is it potentially cancerous or not? So I have this image up. This was a patient that we'd seen that was seen at another medical center, had a pancreatic neuroendocrine tumor in the uncinate. The pancreas has a head, a neck, a body, and a tail. This was in the head. Had a functional imaging that was localized. That is, the tumor was just in the pancreas. And was told at another institution that they needed a Whipple resection. That's the removal of the head of the pancreas, intestine, reconnecting it to the biliary tree and the intestinal tract. In the best of hands, in the best of centers, risk of dying from that operation is about 2 to 3%. We subsequently saw the patient and recommended active surveillance. And I think for pancreatic neuroendocrine tumors, we really could practice precision surgery, I call it, where we're exact and accurate in our management. or pardon what we say in medicine, let the crime fit the punishment, because the disease process needs to demonstrate it's high risk and cancerous and likely to result in the death of the patient. So what is the best way to detect these neuroendocrine tumors of the pancreas? Fortunately, neuroendocrine tumors, this is a little too basic science, but have multiple cell surface receptors that we could take advantage of. That is, they bind isotopes, and we could pick up tumors as small as 4 or 5 millimeter in size. So since we were following patients every year, we asked, well, what's the best test? And can we use it at longer intervals? As you already heard, CT scan is associated with radiation, radioisotopes are associated with radiation. And this study demonstrated that CT scan actually had a higher detection rate of detecting pancreatic neuroendocrine tumors in the pancreas as compared to MRI, and less so those other nuclear medicine studies. So when I see a patient with a pancreatic lesion that's concerning for a neuroendocrine tumor, I always order a pancreatic protocol CT, at least as the initial imaging. And then how else can we determine the tumors present in your pancreas? Is the risk of cancer high or not? And I think FDG PET is very useful for that. And this is, again, comparison of those tumors that are not neuroendocrine tumor in the pancreas with those. And as you can see, there's a higher uptake in those primary tumors. But really, what's important is how can we tell of detecting if it's metastatic or not? Because that's the only reason to do an operation in that patient. We use size, if it's 3 centimeter or larger, but that's not exact. I would say probably 95% of patients end up having an operation for a tumor that's not cancerous, that would be 3 centimeters and larger. So what this showed was that you could measure the amount of sugar taken up by the tumor, because the radioisotope is basically a sugar. And that could determine which patients develop metastatic disease. Now, there's some overlap, but then that would let you avoid doing an operation in the majority of patients that don't have a risk of developing a cancerous tumor. It's gonna, I don't, all right. So eventually we came to the point where we're following patients every year for 10 years and doing CT scans every year and recognizing many of the tumors didn't grow and didn't spread. So the comparison we did then was, well, what imaging modality has the balancing act, right? Highest detection rate of picking up pheochromocytoma, paragangliomas, neuroendocrine tumors of the pancreas, but yet a low radiation exposure to the patients. Our radiologists then compared the amount of radiation exposure, and I was actually surprised. I didn't realize this, but the 68 gallium dotatate actually has the lowest amount of radiation exposure. We then asked, well, okay, that's great, but are we getting the information we need, and is it detecting all the tumors so that we could safely monitor patients? And then I have in the red circle, we compared the dotatate to the CT scan as well as the MRI, and it had the highest detection rate for picking up pheochromocytomas and neuroendocrine tumors of the pancreas. In some instances, Ram will like this, we actually also picked up renal cell carcinomas that had spread because they're actually fairly rich in somatostatin receptor. So for patients with pancreatic neuroendocrine tumors, as well as pheochromocytomas, I think a dotatate scan every 2 years is much more informative. Obviously, you could do the biochemical testing every year to pick up if they have a functional tumor. Lastly, to speak to Nicki in not using the genetic data in our practice, I actually use it for patients with pancreatic neuroendocrine tumor. And again, it's from lessons learned, intervening when we thought it was a neuroendocrine tumor and it ended up not being a neuroendocrine tumor, or intervened and found that it's not cancerous, had not spread. This is a nice study that Amit Tourish did. And we followed 175 patients with neuroendocrine tumors of the pancreas. As you heard, the VHL gene has 3 exons, and the type of mutations could be characterized as missense mutations, and all the others, the deletion, as non-missense mutation. And these are patients that had tumors in the gray zone, where we're kind of scratching our head saying, do they need an intervention? The tumor grew. And patients with missense mutations actually were more likely to require an operation because the tumor grew, or they developed metastasis to the lymph node, as opposed to patients that did not have a missense mutation. And then when we looked at mutations in exon 3, and this biologically makes sense because that's the part of the protein that binds. Patients with exon 3 mutation were again more likely to have growing tumors, or tumors that spread to the lymph node. And I think what's really remarkable is when you put this information together for patients with tumors that have tumors less than 3 centimeters, missense mutation, is it an exon 3? If it wasn't, you could see almost 90+% of patients didn't have their tumor grow, didn't develop metastasis. So when I see a patient in clinic with a neuroendocrine tumor, I always want to know where the mutation is. Is it a missense mutation? And in what exon is it? Because that really dictates what I would recommend. The other thing that's really important to mention is the type of operation done for these tumors should preserve as much pancreas as possible so that the patient doesn't develop diabetes. Many of these tumors could be enucleation, we call it in medicine. They could be shelled out and just the regional lymph nodes removed. As I already mentioned earlier, though, with the new HIF2 alpha inhibitor, belzutifan, this is a patient that was borderline, had a 3-centimeter pancreatic head neuroendocrine tumor, was on therapy for metastatic renal cell carcinoma. We saw him about 9 months later, and he had like a 6-millimeter tumor. So in my mind, it's been a game changer in the sense of some patients I was on the edge of managing their pancreatic neuroendocrine tumor. We ended up not operating. And there's no specific trial for this out there. And we had always talked about using cold somatostatin analogs in these patients with borderline neuroendocrine tumor that might need surgical removal. But I think that's something important to consider, and maybe Ram could shed some light if that sort of trial is being considered, because the morbidity of pancreatic operation is not insignificant. I'm going to finish off by emphasizing how important it is to be in a surveillance program, and this is specific to pancreatic neuroendocrine tumors. We did a very simple analysis. All the patients we were following with pancreatic neuroendocrine tumors that were in our surveillance program, and compared it to a US National Cancer Registry data. And that's referred to here as SEER, over 2,000 patients in that, 153 patients with VHL-associated pancreatic neuroendocrine tumors, and no surprise, it's inherited, so it's a younger age of presentation. The tumor was smaller because the patients were in a surveillance program. But what's the most important thing I want to emphasize to you is when we matched them for age, the tumor size, the grade of the tumor, it was pretty remarkable. You could see patients with VHL had no disease progression, or I should say, had 100% survival, didn't have any disease-specific mortality compared to the national cohort of patients with pancreatic neuroendocrine tumor. Again, emphasizing how important it is if you do have a solid pancreatic lesion that having surveillance will impact your outcome. It makes sense for most diseases, early detection results in better patient outcome. So I'm going to finish up by saying it's really important to get screening and surveillance for pheochromocytoma, paraganglioma, as well as neuroendocrine tumors of the pancreas that are VHL associated. For pheochromocytomas, we really should start screening at age 5 at 1-year intervals. Important if you have a pheochromocytoma that you'll have an adrenal sparing adrenalectomy, regardless if it's only one side. And that if you need a pancreatic operation, that as much of your pancreas should be preserved, and there are multiple minimally invasive approaches to accomplishing this. Thank you again for the invitation to talk to you, and I don't think we're taking questions. We're not taking questions, right?
Yeah, actually, it's just, any questions regarding the first 3 panelists?
Over here. Let me check if this is. Oh, okay.
Yeah, is the dotatate screening available at most centers?
It is available now more and more. It's not at all centers like the FDG PET scan, so that's kind of second best. But more, I think VHL centers certainly should have that capacity and capability.
Okay.
Thanks. Anyone else? Oh, sorry.
I had a question for Nicki. You had mentioned the CC ND1, gene.
Modifier gene.
Yeah. Is there like a blood test for that would say you're at
No,
high
it's a
risk?
genetic test.
A genetic.
So
test?
it's looking at the structure of that gene, and if that little variable region has the G versus the A base pair DNA step in it. So all it does is sort of tweak the risks.
So if you have VHL, then screening for this would be a good thing to do to figure out if you have that higher risk for.
We're not routinely doing that. It's an association that's been noted in the literature, but I think the point is that you need the whole screening for VHL, whether you have that or not. It's just the odds will be higher or lower if you have, depending on which version of that gene you have. But it's not going to change what we do to screen you. Okay. Yeah, it may shift the odds, but it doesn't change. So we're not characterizing it because we're not going to change anything about what we do.
Okay.
Makes sense.
All right. There you go.
I'm just curious. When I was diagnosed, I was never given the type of VHL that I have. Is that easy to identify, or do I have to go through the process again to identify what type I have, or do you know?
So you're talking about the subcategories? Yeah, so I think it's based on family history and presentation and where the general risks seem to be for that family. Okay.
Okay, any other questions?
Yeah, just for Dr. Kabibu, in terms of, so I'm a primary care physician. I was kind of family doc on my brother's case. And so we were walking through this in terms of and just to be clear, in terms of surveillance, so everybody knows biochemical post-adrenalectomy, biochemical screening annually, imaging every 20 or every 2 years. Gotcha. And is that kind of standard of care at this point?
Sure. Yeah, I think it's standard of care, and part of it is, it's complex. I'm discussing specifically the pheochromocytoma and pancreatic neuroendocrine tumor, but by default, you will have imaging for renal cysts and tumors. So what I've often found, and Stephen, you could speak to this, is I end up getting imaging probably every year, but that's not specific to the adrenal glands and neuroendocrine tumor of the pancreas. Because you'll get a spinal MRI and there might be a cut that goes through the kidney, and similarly renal imaging. So I think at default it ends up being every year, but I think the most informative, I guess, the take-home message studies to get, in my opinion, is the dotatate if we're worried about pheochromocytoma, neuroendocrine tumors of the pancreas, but we do get imaging data for the other sites that are not specific. Yeah. Yeah.
I think there's one other question down there. Oh, yes.
I think it was had a similar question. If I'm already getting screened for the every 6 months or so for the kidneys, and I believe my orders are extend beyond the kidneys, is it worth getting the dotatate imaging as well?
Absolutely, because we picked up metastatic neuroendocrine tumor of the pancreas just on the dotatate in patients that were in surveillance program, both at NCI, and I've seen a couple of patients here as well. So I would say definitely.
Okay, any other questions? Great. Okay, we're going to take one more question. Yeah. Yes, right there.
Yes, I have a question as far as the genetics. What does it mean when the gene has been completely deleted? Do scientists know at this point what that means? Because my understanding has been that they don't know what that means yet. And so I did genetic testing at Stanford several years ago, and I've been asking that question.
Well, they have had VHL patients who have a complete gene deletion. And so it means that you have one functioning copy of VHL, the other one is gone, so you don't have a backup. And so you are vulnerable to any change in that working copy can promote the tumors associated with VHL. So we would consider you at risk for VHL related symptoms, tumors.
Okay.
So you being followed for that?
Oh, yeah.
Yeah, so that's why. Okay. Yeah.
Absolutely. Thank you.
Okay, any other questions for this first session? Great. I want to thank Nicki, Dr. Chun, and Dr. Kabibu for this session. Excellent presentations. We're going to take a short 15-minute break. There's some snacks outside. The next session is going to start at 11 a.m. Thank you.